First of all, we're going to kick off with the NHS because under pressure NHS services in England are spending over £1 billion a year buying care from outside the NHS because they're unable to keep up. Well, a lot of people say that is an absolute scandal, further evidence of privatising the NHS. Actually, this has always happened, and when you think about the NHS budget, it's over £120 billion a year, so this is actually less than 1% of the budget. But why is this happening? Why is the NHS now forced to go to the private sector to spend this money? Well, it's being racked up by hospitals, ambulance trusts and mental health trusts because the NHS managers say that this money is being wasted because often it's being spent at the last minute, which leads to the NHS overpaying. Well, it's happening because, of course, A&E units are becoming increasingly busy. They have to send patients onto wards who take up beds which had been meant for people coming in with hip or knee operations. So rather than cancel the operations, the NHS then contract those operations out to the NHS. Now, does that strike you as a sensible way to proceed? I think it would strike a lot of people as very sensible. Or are you just so adamant that we should not be spending money in the private sector on the NHS that you'd rather actually cancel operations? If you do think that, do give me a call, because I think it's a bit of a strange thing, because what you're doing there is surely letting dogma rule over necessity. And what do you say to somebody who's maybe waited a couple of months for a knee or hip operation and you say, well, no, you can't come today, your operation's cancelled because we need your bed for somebody else? Surely the caring thing to do is actually say, well, we can't do it, but we know someone who can. And then they send you to a different hospital and the NHS pays the bill. Is that the sensible way to proceed or not? 0345 6060 973. Let's talk to Dr. Tony O'Sullivan, who's co-chair of Keep Our NHS Public. Tony, very good afternoon to you. Are you shocked that this amounts to $1 billion, and what's the alternative?
Okay, thanks. Well, I obviously detect from your introduction there that you're painting my opposition to privatisation into an ideological corner. But
no, I'm not. I was just trying to outline a few things that I thought people might say. You tell me what you think.
Well, I think if you're talking about somebody in the here and now who needs a hip operation and they're in pain, I'm not going to oppose them going to a source of relief that the NHS Trust guides them to. But I do ask the general question: why, when the NHS was working very well with record low waiting times in 2009, after 8 years of really flatlining funding compared with what it needs, and now running at £15 billion a year less than what it would be if we were at the level of funding, for example, with Germany, Sweden, France, Netherlands. If that was the case, we would not be in this position. What's happened is that trusts are told not to invest to expand their bed base or their theatres or their orthopaedic surgeons, for example. And then, on the other hand, they're told that they will be penalised if they don't hit targets. There's been an assumption from the government that they were going to be closing more and more district general hospitals. Since 2010, they've closed 15,000 hospital beds, including at least 7,000 acute beds, acute including elective surgery. And this is a situation of the government's making. It's a political choice to have run the NHS in this way.
Well, is it?
So it's not just a matter of ideology. It's not me ideologically saying I'm opposed to private medicine. I'm saying that private medicine should not be in the NHS. That money, whether you're saying it's a very small amount, £1 billion going to the private sector is actually very good news for the private sector, and it's not so good news for the NHS when we have been hemorrhaging money out of the NHS.
It's what, 0.8% of the money the NHS gets every year, so it's a comparatively small amount. I would say here what we need to think about is what's best for the patient, and surely what's best for the patient is to have the operation on the day that they were planning to have the operation, whether it's done by the NHS or whether it's contracted out to a private provider in these kind of cases.
Well, you're not going to get me to disagree with that. What I'm saying is that what the here and now situation is the shambles of political making, and the NHS workforce strategy, funding strategy, etc., should be that the publicly provided NHS can cope with a totally predictable increase in demand. This isn't a shock. We've known it. If we listen to public health needs assessment specialists, you know that the population is rising a certain amount, the ageing profile is changing, elective surgery needs will be gradually going up. There's no shock here. What has happened since 2010 is a change of ideological position towards public provision of healthcare.
Well, two things.
You know that because that may be something that you possibly agree with, but I don't agree with it.
Well, I'm not sure I agree with you that this is a political decision. These sorts of decisions are surely made by NHS England. Simon Stevens is the chief executive of NHS England. I can't imagine that Jeremy Hunt is poring over spreadsheets of operation numbers. That surely is Simon Stevens' job.
But surely you would recognise my point that if trusts up and down the country are actually running at a loss because the funding hasn't been there,
or they haven't been run efficiently.
Well, I was a paediatrician until 2 years ago, and I can tell you that I spent the last 10 years constantly looking for savings and being more efficient, in inverted commas. It's longer than that. The NHS, you probably know this, has been assessed internationally as the most cost-effective major major national health service in the world, and that does not make it perfect. I completely agree that efficiencies and improvements can always be made, but on a bedrock of really large underfunding, huge transformational change is impossible. And what's happening now is the cumulative impact of 8 years of deliberate deficit funding and withdrawal of beds.
You've been at the sharp end of this. I haven't, so I will defer to your first-hand knowledge of this. But would you not agree with me that this isn't something new? It's this money that's being spent in effectively contracting out operations. This has happened 10, 20 years ago. It's not just happening. It's something that's not just happened over the last 8 years. I can remember a debate in 2004, 2005 about this, and the Labour and the Conservative opposition was saying there should be a lot more of it then. I mean, it was happening, but they said, well, look, the key thing here is the patients. It doesn't matter whether it's done in the private sector, let's spend more money doing it in the private sector.
Yeah, 2004-05 goes back to the Blair period. Yeah. And there were two things happening at that point. One, the Labour government poured money into the health service, which redressed a period of starvation under the Thatcher Major period. And there's a huge improvement in delivery of healthcare. A&E waits went down, elective surgery waits went down, cancer waits went down, and cancer survival was beginning to improve. There were all sorts of improvements. Tony Blair bought into the Thatcher position, basically, that competition in healthcare is going to drive efficiency. Now, since that time, we actually know, and this isn't an ideological position, it's true, that competition in healthcare, in a public access to public healthcare, has been inefficient and has sort of disintegrated the health service. There's the gross examples of the PFI contracts like Carillion and the inefficient cleaning of hospitals in Leicester and Nottingham and so on. But there's also the impact that a national health service should be about collaborative and integrated care across sections of the health service and with your important agencies in social care. And in fact, the market has driven competitive tendering and one company, one plus trying to do better over another.
What I would say is that bad experiences in 2 or 3 hospitals in Leicester and Nottingham does not mean that every single experience has been bad. But let's leave it there. Tony, thank you very much. That's Dr. Tony O'Sullivan, co-chair of Keep Our NHS Public.